No, I do it.
Recording in progress.
Hello, everyone. Can you hear me? Can you hear me clearly?
Yes.
All right. Perfect. Thank you. Okay. Time to ask you questions now. Okay. Who's going to answer me regarding DLCO? How do you think it gets impacted in emphysema and what will happen? volunteers for the exercise? It's going to decrease. Very nice. Yes, Andrew, please go ahead.
Oh, yeah, I said it was going to decrease.
So why? If you apply this law, why?
Oh,
Yes, Diego. Go ahead.
Is it because of the decreased coefficient of lung diffusion so if you have an increased cardiac output, a decreased lung diffusion, and then their cardiac output is higher, then there will be less time for oxygenation of the blood at the interface alveolar and arterial. Thus,
Yeah, but the main reason, yeah, Jay has answered, Aaron has answered. So basically, you have the surface area that is getting impacted in this scenario, right? That will impact your diffusion, rate of diffusion of the gas, right there. You see my point? That was my question, basically. So, what is the factor out of the law that you apply the most for any certain pathological state that I'm asking you? Yes, Usman. That's the rate of diffusion, how oxygen is diffusing through the membranes, through the alveolar membranes, right? You got it? All right. In fibrosis, what's the factor? Yes, Diego, you're right. So that's in case of fibrosis, right? Thickness of the membranes. Is everyone with me regarding this, or you have any questions? As I told you, this is the biggest factor here, the denominator, right? That's the biggest factor that will impact the diffusion in case of fibrosis. If membrane is thick, diseased, it won't allow a good diffusion of the gases through, right? What's going to happen in pulmonary edema and why? Yes, Jessica. Mara, please go ahead.
Well, in pulmonary edema, you have increased interstitial space, and that's a buildup of fluid that will increase the thickness and decrease the diffusion capacity, resulting in a high AA gradient.
Beautiful. Very nicely answered. Thank you so much. Beautifully answered. Yeah. Yeah, it's likely the surface area as well because the edema is sitting there, but mainly it's the diffusion distance is increased, which is causing the major issue here, right? What will happen if you are exercising? How does your DLCO get impacted if you are exercising? Anyone? Beautiful, because your capillary perfusion is better, right? You can diffuse more oxygen in. Very nice. Okay. And anemia? It will decrease or increase? Decrease. Very nice. Because you don't have enough hemoglobin available, right, to carry the oxygen. And polycythemia, what's the condition, first of all? And what will happen to DLCO? Yeah, more RBC number, right? And it will increase or improve. Beautiful. Very nice. So just be ready for different stems for the exam. Usman, kidneys don't produce RBC. Kidneys produce erythropoietin, the protein, which goes and talks to your bone marrow to do the erythropoiesis. That's where your RBC production is going to happen, right? All right. Yeah, you are absolutely right, Usman. Basically, you will have more erythropoietin formed before polycythemia, and that will go and talk to your bone marrow to get you more. All right, so A gradient changes. Can you give me examples? what pathology can lead to a gradient change? I'm just trying to induce the thought process, and then COPD, very nice. Fibrosis, very nice, Chris. So how? Now you got to tell me how in fibrosis, how in COPD and asthma, how do you impact the gradient?
Ma'am?
Yes, Paramveer, go ahead.
So, in cases of fibrosis, for example, the alveolar walls would be thickened, which would impact the impact the exchange of gases and the overall pressure gradient. And in cases of asthma or COPD, it would be increased. It would be a decreased pressure gradient.
Yes, very nice. So even if you have 100 here, if membrane is thickened here, it's very difficult to diffuse all 100 into the capillaries, right? So you may not end up having 100 into the arterial blood supply, right? You may end up just having 90 or 80 or something. So your gradient is going to get increased that way. And how about emphysema? Any other volunteer? How would you increase the gradient in emphysema? I know you already answered. It will be increased, but
Okay.
how? Why? Paramir, you want to take it?
Yeah, so since the pressure gradient would be increased because since the walls are thickened, if we look at the equation, the pressure gradient as the alveolar equation, if you increase the membrane thickness, then that would lead to the pressure gradient increasing as well. If I'm right or not, sorry.
Not correct. Anybody else? Let's go and have the direct answer to this. I'm sorry, Paramir. Yeah, the capillary network is not as functional. That is one of the reasons. Very nice. Your A gradient won't be good because much of I told you, like if this is your alveolar sac and capillary network sitting up there, right? And this is all inflamed underneath, and this whole bed is gone, basically. Yes, Abraham, you can go ahead. That's one of the reasons that I just mentioned.
Oh,
Abraham?
okay. I was just about to say that. I will say the destruction of the alveolar septum and capillaries, and then you have the reduced inelastic recoil.
Reduced of coil is not impacting your gradient. Keep that in mind. The elastin fibers is different.
Okay.
Yeah. Jasmine?
Would it be because the forced expiratory volume is a smaller value?
No. So if I go back and here, this is sitting here, right? In front of you. Now you can apply the same thing and come back to the A gradient. Dhruv, do you want to explain it?
Sorry, are we talking about emphysema?
Yes. Go ahead, please.
Oh yeah, I think it's because there's a decreased surface area for diffusion, so then that causes an increased A gradient because less is being diffused to the from the to the capillaries or
Yeah, so Ahmed is writing something. Basically, these are the alveolar walls which are getting damaged, right? I told you there are 2 or 3 alveoli merging together to make one big alveolus, right? If you had these smaller alveoli sitting there, you have more surface area to do the gas exchange. But if walls are broken and there is a big alveolus, you lose the surface area there to do the gas exchange. That is major reason for emphysema. That's one of the major reasons for emphysema, to reduce the surface area there and do the gas exchange. Second important reason is the capillary network that was sitting on the surface. If that whole bed is damaged, then that's another major reason that the diffusion won't happen as good. Yeah, I mean, the surfactant, if the pneumocytes are getting impacted, if it's all inflamed, yes, your surfactant eventually, as a person is aging and they have long-term COPD, they're gonna impact the surfactant making too. And there will be atelectasis actually at the end of the lungs, lower portion, base of the lungs. All right. Okay, so I think you guys are doing well on this. Can anyone answer me this question? If you have a patient with severe case of emphysema, which gas diffusion curve oxygen will follow? So we have nitrous oxide here, we have carbon monoxide, we have carbon dioxide. You just need to know first, these gases follow which of the diffusion curves, whether it's diffusion limited or perfusion limited. If you know that, then you can answer the question. Jay is right. Jay, do you want to explain it? Yes, Fatima. It's diffusion limited. Very nice. Do you want to explain it? Why? Yeah, in case of, go ahead, somebody else wants to answer. You are right, Jay. It's gonna be, later stage of the lung disease. It's diffusion limited. And for all the reasons that we just discussed, you lost the surface area, you lost the capillary network there. And one more thing. So when there is hypoxia in case of emphysema, you also have capillary vasoconstriction. The capillary network you have up there, we call it hypoxic vasoconstriction, in order to shunt the blood to better ventilated areas. So blood will be shunted to other areas. So some areas will be vasoconstricted, and that is another reason that your oxygen is not diffusing as well. We will talk about it in week 3 and complete the story. I haven't discussed it yet. It's going to come in week 3 material. Yeah, that's partially the reason, but basically we are looking at oxygen diffusion, Thomas. That's the primary question here. Anyone who can explain me what is the difference between perfusion limited and diffusion limited curves? Can anyone explain it? Do you all get it? Yes, Andrew, please go ahead.
Oh, sure thing. Thank you. So in perfusion limited, basically the ventilation of gas, that's basically the pressure is based on the amount of blood flowing through the capillary. So in order to decrease in order to decrease the gradient, you have to increase the blood flow. But basically for diffusion, it's basically limited by the difference in the partial pressures between the gases.
Yeah, let me explain it further. So basically you have two types of curves. Abraham, do you want to say something?
Yeah, I was gonna help him, but it kind of glitched. I apologize. I wanted to add to his diffusion. It's
Yes.
more of a structural problem in the lung that affects the gas exchange versus perfusion is the opposite way, where it's more of a like gas itself. So diffusion's like if you lose your surface area or if it increases in membranes, diffusion impairment versus the other one. I was just gonna add to what Mr. McGuire said.
Yeah, let me say it more clearly. Thank you, though. Thank you for your input, both of you. So basically, gases, they will follow two types of curves in your body. One is when they get limited or their diffusion gets limited by certain reasons, and that could be any reason. Can you think of any reasons that can limit diffusion of gas in your body? Edema, very nice. COPD, very nice. Beautiful. Pneumonia. Yeah, you said it all. So just keep in mind, I told you that otherwise oxygen follows a perfusion limited curve. That means it's soluble in blood. And I told you, if this green dot that you see, this is length of this whole thing is your capillary, right? And blood is flowing through it, right through the capillary. Now this is your alveolar surface out there where I put this thing up here. This is your alveolar surface. Your O2 is 100 right here. Now you want this O2 to get into this capillary, right? So blood is perfusing through it. Oxygen is very soluble, so is N2O, or so is carbon dioxide. They are pretty soluble because, they have great solubility in the blood. So they will drive the pressure gradient, or they will drive the diffusion of the gas into the blood. So they will quickly, as soon as the blood starts moving from the alveolar surface, they will go right into the blood. So in case of N2O, as you can see, by even 1/3 of the capillary, the whole gas which is sitting up here on the alveolar surface, it's already in, right? For oxygen, it is by 1/5 of the capillary, it's already in because it's soluble. Same thing with the carbon dioxide. Now there is more blood flowing, but you don't have, if the blood flow has somehow improved, if you are doing exercise, you can bring in more oxygen during this capillary because you are in equilibrium at the alveolar surface or the arterial blood already 100 and 100. You see, this curve is showing you the equilibrium. So this is partial pressure of oxygen, this red line, and it's matching the green dots, which was 100 out there, right? So they are in equilibrium now. What was out there is already in. But somehow, if you were exercising and you are increasing the blood flow here, so if you are exercising, you are actually increasing the blood flow 5 times how it's moving through these capillaries, right? So if you increased it, you're going to get more oxygen loaded, what we were earlier learning in the class, right? If you do exercise, you improve your DLCO. So from perfusion limited, you can improve this oxygen coming in, right? Now, if we move to a diffusion limited gas, in case of carbon monoxide, the problem with carbon monoxide is you don't have any carbon monoxide in the blood, right? There is 0. Here you had 40 in the venous blood, the oxygen 40 in the venous blood and 100 out there. You had good gradient, so things are moving very nicely. Here, carbon monoxide is lot outside in case it's coming in. You have 0 in the blood. So there is a good chance that it starts to come in. But problem for carbon monoxide is as soon as it comes in, it's not soluble. Everything goes and sits very tightly on hemoglobin. As long as it starts getting fixed, it stops any more diffusion. So the curve becomes diffusion limited. As you can see, the blood is flowing, but this red line is way away from the green line. They never get to the equilibrium. What is outside is never going to get in more. Only the problem is when somebody is going through carbon monoxide poisoning. That's a different story. I'm just talking about a regular carbon monoxide exposure, small exposure. So here it becomes diffusion limited. Okay, so any scenario which will be a diffusion limited scenario that will make the curve diffusion limited, that means this gas is not diffusing anymore. So if you were doing strenuous exercise, your blood flow is so fast that it went through the capillary so fast, you were not able to diffuse as much as you could if you were just doing a normal exercise. Then it becomes diffusion limited. Or if in case of fibrosis, if this membrane was so thick that it won't let diffusion happen that nicely, that will take away the diffusion too. So your curve changes from perfusion limited for oxygen to a diffusion limited. Yes, Amir.
Hi, Dr. Kaur, can you hear me?
Yeah.
Oh, okay. Thank you. So basically what you're saying is for diffusion limited, it is gas exchange is limited by the how efficiently how gases can exchange between the alveoli and the capillaries. While for perfusion limited, it just depends on how quickly the gas can pass through the blood.
Say it again.
So for diffusion limited, it's based on how
If your
efficiently.
diffusion of the gas is impacted by any of the factors, then it's diffusion limited. If there is a problem with the perfusion, whether it went too fast, if perfusion was too fast and gas didn't get time to get diffused, or if there is no perfusion at all, as in case of emphysema, we discussed the whole capillary bed is gone. So then it's a perfusion limited. So emphysema is a good example of diffusion limited as well as perfusion limited. You can consider both.
Okay, so yeah, so basically, okay, and if any of the factors that are in the diffusion equation are affected,
Fibrosis, for example, is going to be diffusion limited, right? Because you
okay,
have
that makes sense.
membranes, right?
Yeah,
Edema is also diffusion limited.
right,
So
right,
edema, you cannot cross the fluid that is sitting as nicely, quickly,
yes.
right? Yeah. Asthma would be also depending upon how much air is really getting in, whether you have good alveolar number there, based on that. You know, I think people should still be doing good because their lungs are not impacted at all. Their asthma could be you know, perfusion limited, you can consider, but most likely there is a good chance that, things are going well there and you have as much air present. It's only the obstruction at the airways which is causing the problem. So what are you saying, Diego, here? You're talking about carbon dioxide and carbon monoxide.
Yes. So when they were explaining about the preference of hemoglobin or like the diffusion rates, I remember that there was a section that said that carbon dioxide related to diffusion limiting, it will just go through and it will never stop because it will never reach full maximum saturation.
Yeah. Yeah, it's basically the affinity for the for the hemoglobin, for both carbon monoxide mostly. Carbon dioxide is very soluble. It's like 3 to 5% it's soluble, so it goes readily in. But the carbon dioxide, as I told you in class also, you should appreciate nature that way, that your carbon dioxide production, as much as it's happening, it's doing the carboxyhemoglobin thing, which can be toxic for the tissues, but it's changing 91% carbon dioxide to your best buffer that your body can have. So instead of confusing yourself for the affinity and all that, just focus on the solubility of that gas, which will drive the partial pressure.
So those numbers do not relate to solubility. They only ever are related to affinity for hemoglobin.
Yeah.
Understood. Thank you.
Yeah. Yes. Okay. Usman also answered in there. All right. So be good on this. Can you identify which fibrosis? It's a diffusion limited, right? For emphysema, it's mainly diffusion limited because loss of the surface area, but at some places we can't say totally perfusion limited because some places there will be capillary network erosion, that can also lead to the perfusion limitedness. Is that clear? Yeah, it's both, but mainly diffusion. Okay. And fibrosis is typical diffusion. Okay, so here is the story now. For A gradient, if we are sitting at a different atmospheric pressure, so this tells you nicely, if you are at a sea level, a normal person, which starts at 40 mm, and here is your alveolar surface, which is 100, right? The green dotted line. The normal person will get into equilibrium for oxygen by halfway through the capillary, right? You got into 100 and 100, 100 out, 100 in, right? Everyone clear? Yes. Now, in case of fibrosis, you have a thickened membrane here. They will have hard time. They started from 40 venous O2. They'll have hard time getting that O2 diffused, and they would never get to 100. So they're going to end up like somewhere 90, 85, 90, somewhere there, depending upon how fibrotic the lungs are, right? So just keep that in mind. This is what I meant, why we call it diffusion limited, because they'll be a little short of what is sitting out there on the alveolar level. Yeah, we cannot bring in more oxygen. Same thing with pulmonary edema. If you have, more surface area, more area to cross, the distance to cross, you are not diffusing as good, right? Now, here at high altitude, we say that the atmospheric pressure was really low, right? So the alveolar surface, so let's say we are somewhere really high, hiking, and the alveolar pressure is only 50. We are talking about oxygen here. So let's say outside it's 380 atmospheric, and out of that, your oxygen is 50, halfway. So 50, a normal person would have in the venous blood only 25. But they will still, they're not going to have a difference in AA gradient, the normal, because their lungs are normal. They're going to get, the problem here is the pressure gradient is much smaller, 25 versus 50. Here we had 40 versus 60, so it will diffuse quickly there. Now your pressure gradient is smaller, difference is small, right? So it will take some time to get there, but finally it will get there. Now, people who have issues like fibrosis and they are sitting on the top of the mountain, that's why they will be breathless completely, because they started with 25. They want to get to 50, but membrane thickness and the pressure gradient difference is making it even harder. So it's really big diffusion issue here. So Deborah is asking, A gradient decrease. Yeah, if they are living at sea level, that's why they'll have hard time on the mountains, right? They'll go breathless. But if they're at the sea level, at least they won't see this much, because they're just going to see like 10 mm difference. They can still survive with that. Because your saturation to hemoglobin will still be good at 90 mm oxygen. You see my point? Yeah. So yes, Diego. Affected due to atmospheric pressure is low, right? And if atmospheric pressure is half the number, 380, let's say 380, it will only have half the oxygen there. Does it make sense, Diego? Okay. All right, so you has a big role to play, right? And any other pathology that is at the lung level that will have a role to play in diffusion of the gas too. So, that will impact your A gradient, that will impact your diffusion. So just keep in mind all those things, right? All right, next exercise that I had given you. Now tell me, how does your total lung capacity do in case of fibrosis? Anyone? Very nice, Michael. Total lung capacity is going to get decreased, FRC going to get decreased, residual volume is going to get decreased. Can you tell me why? What's going to happen with FEV1 FVC ratio? That's going to get increased. Very nice. Why? You have to tell me why. And what's happening with DLCO? Lung diffusing capacity. Go ahead, please, Abdul.
It has problem with inhalation, so you would not inhale as much as you would inhale normally. So it would decrease.
Yeah, but why? Why inspiration issue?
Thickening of the membrane.
Yeah, thickening of the lung membranes, right? And they have high elastance now. Stiffness is there, right? So moment it tries to inspire air out, it can't inflate as much and it will just snap back. So patient will definitely not able to retain that much of ERV, or the residual volume will be much smaller that they are keeping in lungs. This is all going to impact their TLC. And, their FEV1 FVC ratio is going to get increased because they are breathing right out. Yes, Abraham, what's your question? Do you want to say it?
Yeah, I'm just I was wondering because I know the book I have, it says that for restrictive diseases, it could either increase or stay normal. Is that
Yeah, it can stay
it
normal.
is okay.
So
I was
as I
just
showed you last night, the
Mhm.
loop looks very similar to normal. It's
This
just
is-
because their whole FVC is smaller, their whole TLC is smaller.
Mhm.
The shape of the loop is similar. So that may
Oh,
not
okay.
impact your FEV1 FVC ratio sometimes. Most of
Mm.
the time it's increase and that gives you like very good representation, but you always want to see your patient with a greater lens. That means you want to see the symptoms, how they
Mhm.
came into your office, right? What was when it started happening, how long. Usually these are young patients, right? It hasn't been a very long time that they have had it, and it's usually dry cough because of we are talking about silica, we are talking about asbestos, or any other, the coal mining and all those particulate matter that is settling in the lungs and causing the issues, the interstitial fibrosis that we are talking about, right? So look for
Thank you.
all the symptoms and causes for sure. Pretty much, Diego. You can appreciate it through this is for you guys. Try to interpret it yourself. Okay? You see this comparison to this. This is normal, this is restrictive, and here is the obstructive. How much RV the emphysema patients will be retaining? Yes. Diego?
Sorry, but it was throwing me off. Why is only the exhalation reserve volume and the RV highlighted on this one? Why only those two, one, not the whole thing?
No, I was just giving the comparison. I did the highlighting. I just
Oh, okay.
wanted to give you the comparison. So this didn't come with the picture itself or the image itself. I did it. I just wanted
It's a
you to, yeah, it's a complete
it's a
shorter.
comparison only between obstructive and restrictive, not necessarily between normal and restrictive.
Yeah, with normal as well. You see that? How much
Yes, I do.
is here? And this is much smaller.
Yes, I do. It's just that because it was out of context, I just was like not.
Yeah, no, I put it just I wanted you to appreciate like how much smaller ERV is here as compared to the normal one, right? And RV also since they can't keep air in, right? So Joy is asking what is the difference between vital and force vital. So it's like after a maximal inspiration, if you try to forcefully expire air out, that is your forced vital capacity. But if you are looking at the, regular inspiratory reserve and regular expiratory reserve, that would be your vital capacity. Forced is forced. Joy, does it make sense?
Yes, thank you. So, I think I'm asking kind of in terms of these math problems, like, if a test question is asking about vital capacity or forced vital capacity, they would be different then.
Yeah. But we will be clear. Force vital capacity is just going to come in connection with if we are talking about any pathology, because that's the measure for your PFTs on spirometry. You see
Okay.
my point?
And reasonably forced vital capacity would be bigger than that. Whatever the VC
Yeah,
is,
it
the
should be
force would
slightly
be.
bigger. Yeah, it should be slightly adding up.
Okay, thank you.
Yeah. All right. So next question. With emphysema, now please tell me what's going on. TLCO, FRC, residual volume. We just saw that. Total lung capacity. What do you think is happening? Beautiful. Yes, Amir. Very nice. What's going to happen with the ratio? The ratio is going to get decreased. Why? TLC is going to increase. Very nice. So if I go back to this slide, you can see how TLC is a combination of enlarged ERV and RV. RV is the main thing, actually. That is, these two things are making your FRC, right? So your FRC is much higher, and that is adding up to your TLC. You got the point? Everyone got it now? So basically, why this ratio is decreasing? Can anyone tell me? Why FEV1 FVC ratio is decreasing? Can anyone volunteer, please? Why you have the ratio decreased? Yeah, very nice. So basically you have obstruction in the airways, right? You are not able to exhale as good. You may be having inflamed airways, or they are full of, phlegm and stuff, the mucus and everything. So patient is having hard time releasing that air out, which is basically retaining more RV and ERV there. Yeah. Good. Very nice. I'm leaving this question for you guys. Just see what So, the partial pressure of oxygen in your body typically will cause the saturation of hemoglobin. So can anyone answer this question? Yes, 75% is at 40 mm. So see, this is funny. When your train of goods is coming back as venous blood empty, your hemoglobin moieties are still, 3 of them occupied, 75% are still saturated at 40 mm. See, only one subunit is empty by that time. So just, wanted to bring the significance out of this. Everyone is aware of P50 curves. You guys know about P50 curves? Why would a curve shift to right? What are the reasons for the right shift? To unload. Very nice. Lesser affinity, that would decrease the affinity of oxygen, so it can unload. And whenever the causes are, whenever there is more carbon dioxide formed in the tissues, the pH is obviously going to drop because of the hydrogen ions, right? Those are being made when the carbon dioxide is metabolized here, right? And then temperature, the heat that you can relate with the exercise too. And then 2,3-DPG, that's going to get increased. What's the significance of this? Yeah, it's worse. Very nice. So right shift when you need oxygen unloading in the body. Left shift when it's having such a strong affinity and body thinks that there is no need of unloading. That's the low temperature, pH is alkaline, there's not much carbon dioxide that is being made. Your glycolysis at RBC will also be down in the form of TPG there. Clear? Everyone is clear about that? You have done in biochemistry, so I won't spend much time on it. Are we good? Yes. So basically, 2,3-DPG increases for several reasons. One thing is that, it wants to give an indication for more unloading. Plus, you have polycythemia at high altitudes. People who are living for long term at higher altitudes, they'll have more erythropoietin release, which is going to ask for more RBC formation or hematopoiesis, erythropoiesis from bone marrow. So you have more hemoglobin available or more RBCs available. 2,3-DPG is basically your byproduct of RBC glycolysis, right? So you'll have this more, and that's gonna actually lead for the unloading of oxygen from there. Is everyone clear? We good on this? I just wanted to do one question on this. All right, please answer me when you're ready. Which of the following is correct? So Amanda is saying C. It's not D, it's C. That's the correct answer. Amanda, can you explain, please?
Yeah, so as we like alluded to in the other slide before, when we shift the curve to the right, we're having greater offload of the oxygen to the tissues. So we would have that increase of 2,3-DPG as well. And again, like it would be the rightward shift.
Yeah, so basically leftward shift is gonna decrease O2 affinity, but is it caused by temperature increase?
The rightward shift is caused by temperature increase.
Yeah, so basically it should be the lower temperature, right? Here, leftward shift should be the lower temperature. Then leftward shift increases O2 affinity, decrease in pH. Is it decrease in pH?
The rightward shift
would be the increased pH, right?
Increase in
Alkaline
pH, yeah.
pH, very nice. And last one is the rightward shift increases O2 affinity. That is wrong. It is decreasing O2 affinity. Is everyone clear about these? You're going to see questions. Definitely. I think there will be some question by Chem 2 and for Physio 2. So, yeah. Just keep in mind the DPG is a byproduct. As I said, it binds to the beta chains of hemoglobin, and that it reduces because beta subchains are binding to O2, right? So when you have DPG increasing, it's going and binding to the beta chains and thus reducing the affinity of O2, basically. So keep those in mind. I think this is it for today. Make sure if there are any questions left over, just go over them. What's your question, Amir, here on 7? I didn't get it. Amir? How did you arrive to this answer? You can look through the curve, right? Where is your 40 mm? It's right here. That's your mixed venous pressure, O2 pressure, right? How much binding is it doing? It's 75%. That's given. That's solid.
Sorry, Dr. Kaur. So I just want to, sorry, so, okay, so you got it off the curve, and if we ever to get a question like this, will we have a curve, or we just have to just
No,
like
you
know?
have a table in the book that gives you at all the pressures how much affinity is there.
Okay, thank you,
How
because
much
I didn't
binding is there.
understand.
Yeah,
I
you
got,
got to finish
yeah,
the table. That's
appreciate it.
standard. That's standard. Okay.
Okay, thank you.
So are we good? Any other questions? I think we have gone over like pretty much, I've tried to cover how we are moving like from this point to that point and finishing up the gaps. So now we have week 3 left. Whatever A gradient stuff left, we will cover that in week 3, and then that's where we will finish with the A gradient equation. So you may see questions. I told you before, you're going to get questions for alveolar ventilation. You're going to get questions for alveolar gas equation. Challenge yourself enough. You're going to get questions for A gradient calculations, a big part of this exam. So be ready. Challenge yourself a lot. We have TA review ready as well. I'm just going to go over the slides today. There are a number of slides. This year I asked TAs to make separate reviews. So you have ANS separate than POM, so it will be much easier for you to go through the slides. And for DOs, we have got ANS Farm separate review with ANS. So, they'll have totally entirely different. So MS will get just what they need to do, and DO will get what they need to do. TA review, I have to check with them. I believe they do Thursday night, but I'll check with Jackson once I send him my TA review edits today. I will check with him. Okay, and then I will let the CRs know. For the weekly review for this session, I will send you a time when I'm ready. I see that on Thursday morning, 9 a.m., there is nothing before anatomy. Can we meet then, like for 30 to 40 minutes? Not like long session, but a quick one.
Aren't we meeting